And good evening. Thank you for watching HealthLine on PBS Fort Wayne. I'm your host, Mark Evans, sitting in for Jennifer Blomquist tonight. And a very important topic because we're getting into that season. It's the season of sunning, laying out in the sun and enjoying that and getting all the vitamin D you can and toning our skins down a little bit. It's also Skin Cancer Awareness Month. And the main reason why we're doing this topic is because of that. It's melanoma. And considered to be the deadliest form of skin cancer, but is highly treatable if detected early, according to the American Cancer Society. And cancer of the skin is by far the most common of all cancers in the United States. Joining us tonight, Dr. Robert Bednarek. He is a doctor of micrographic surgery and dermatologic oncology. Great to have you back on the show today.
Thanks, Mark.
It's been about 5 years since you've been here.
It has been, yeah.
Well, welcome back, and I'm so glad you're here for this very important topic and during the month of May.
Yeah.
We're going to go ahead and just preface what's going to happen on the show. We're going to talk about melanoma, what causes it, the treatments, and so forth, but we also want, of course, audience interaction. And we have a couple ways to do that. You can give us a call, and you can either stay on hold for a short time and air your call live, and we love hearing your voice. But if you just want to leave your question with us by calling us, we can transcribe that for you. Another way, a fairly new way here at PBS Fort Wayne, is to text us your question. And that text number is on your screen as well. Now, when you do that, please give us at least your first name and the town from which you're texting so we can give you a nice shout out because we appreciate your viewership. So, doctor, let's go ahead and talk about melanoma. What is melanoma? What causes it? And let's throw in some risk factors.
Absolutely, okay. Mark. Yeah, so melanoma, just like any cancer, is kind of described by where you have like abnormal growth of cells, so to speak. So in this case, it's derived from the melanocyte. So the melanocyte is, there's three layers of skin. So there's the epidermis, there's the dermis, and then we have kind of normal fat. So generally those melanocytes kind of reside in the bottom portion of that top layer of skin, and the epidermis is kind of their normal home, so to speak. Mm-hmm. So they play a really important role in protecting the skin. So we usually think of them as tanning. So what tanning actually is the melanocyte reacting to ultraviolet radiation, and it's the body's attempt to protect the rest of the skin. So what melanoma is when we get aberrant growth or mutations in that melanocyte that subsequently leads to abnormal growth and subsequently a melanoma.
So the melanocyte, mm-hmm. Does it give up? I mean, is there a void there? Is that the reason why the melanoma does form? Why is that?
No, so actually, and funny enough, if you look at normal skin biology, we all, regardless of what skin color you have, we all have the same number of melanocytes. So whether you are, fair skin white or have black skin, the number of melanocytes is generally unchanged from person to person. Mm. The reason some people get darker is that there is an increased number of what is called the melanin, which is the byproduct of the melanocyte that's, again, kind of making that skin darker. And it transfers those to the other cells of the epidermis called the keratinocytes. So so we all have pretty much the same number of melanocytes. It's when we get that increased growth. So an aberrant, like if you get again, we'll talk about risk factors here shortly, but again, the biggest one we'll kind of hit on is ultraviolet radiation, where it causes the stop factors of growth to go away, so to speak, or causes the promoters, so things that want to push that cell into making more cells, so bad cells, I should say. That's what leads to the melanoma.
Okay, and so we're not only talking about natural sunlight, we're talking about tanning beds as well.
Correct.
Okay, which one is safer?
So there's really not a safe one of either one. So ultraviolet radiation, if you look, is the tried and true number one most controllable factor for skin cancer in general, but also melanoma. So the way I kind of look at risk factors for melanoma, I kind of characterize them as, genetic or things you can control, and then there's the environmental things, or those are the things that you can control, and the genetic ones that you cannot control. Right. So in terms of environmental ones, the ones that you can control, most of them are going to be looking at our ultraviolet radiation. So sunlight that you're getting outside, UV light or ultraviolet radiation that you may be getting from a tanning booth, those are primarily kind of the two big main ones that we are seeing. And then we kind of have the non-controllable ones, or ones that you're kind of born with. So intrinsic factors that you can't control, having blue eyes, having fair skin, being more prone to freckling. Some patients or people are born with decreased immune systems, so immunosuppression is also something that can be attributed to the factors that you can't necessarily control for yourself, but that may also contribute to increasing your risk for melanoma.
And you know, melanoma is also, it could be evident not only on the skin, and we're going to talk primarily about skin tonight, but I wanted to throw this into, you can have it in your eyes or in places that you can't even see.
Absolutely. So, you know, I talked about the melanocytes in the upper layer of the skin, which is where they normally like to home in. But during embryology, we also find them in other places too. So as you hit on in the eyeball, so occasionally, a lot of times people that are diagnosed with melanoma are encouraged to see an ophthalmologist to make sure that they're getting the back of their eye examined to make sure there's not something called a uveal melanoma. We can see it under the nail beds and other places that you may not expect to be, you know, exposed to sunlight. So as you kind of hit on earlier, kind of the mucous membrane, so the oral mucosa or even the genital skin at times. Again, areas that you may not necessarily have exposed to sunlight, but we also have a home for the melanocytes, so to speak. So whenever that home exists, there's also the potential for those becoming neoplastic or becoming cancer.
And you mentioned some of the reasons for people getting melanoma, but the exact cause, I guess, has not really been pinpointed.
Yeah. I mean, we know some genetic things that can potentially lead to certain melanomas. We also know that UV or ultraviolet radiation causes and damages the DNA structure of not just, you know, the melanocytes, but really all the cells. It has the potential to damage all the cells in the skin, so to speak. So yeah, we can't always pinpoint exactly what the mutation is that leads to subsequently forming the melanoma, but we know kind of the just contributing factors.
Okay, and we talked about some of the risk factors, the skin that burns easily, having exposure to UV light. I noticed another risk factor while I was doing my research earlier today, that having many moles that aren't typical. And we're going to take a look at a picture of some of those moles in a minute. Living closer to the equator or higher elevation, which makes sense to me.
Yep.
But are there any people, and I don't mean to throw you off guard, but is there a particular place or places in the United States, for instance, that melanoma is more prevalent?
Yeah, and I think a lot of times we see it more in the South. If you look at the incidence rates, it's going to be higher in the South. And as you might imagine, there's a higher burden of ultraviolet radiation in those areas. There's sunnier climates, there's sunnier longer throughout the year. So subsequently, we're seeing probably a higher incidence of melanoma in Florida than we may perhaps in Alaska, so to speak. Mm-hmm. So no, absolutely. I think, again, I can't necessarily say with certainty, but I can only imagine if you look at the incidence of melanoma, comparing those populations of people, that is certainly going to be higher in the sunnier states.
Do you see a lot of it here in this area?
We do, yes. We see a high burden, and I think, again, a lot of it comes down to, at least in our community, we're certainly probably an access-restrained area where patients may not have, or people may not have as good of access to care as other areas. So I would say the incidence is probably what would be expected for other Midwest areas. But I will tell you that because we live in a Midwest and rural area, we tend to see them when they are more advanced than perhaps when they are thinner and a lot more treatable. So no, absolutely.
Okay. I want to move on. I want to take a look at some photos that you brought along.
Yep.
And we're going to take a look at what melanoma looks like. And if you don't mind, you can go through those slides
Absolutely.
and explain what's going on.
Absolutely. So these photographs that we have here are true ones taken from people in our community. So this right here, I think the biggest thing when we are evaluating, or a provider is evaluating a spot or a mole of concern on a patient or a person, is we kind of go through what is called the ABCDE criteria. So A stands for asymmetry. So am I able to cut this mole in half, and does it look the same on both sides? In terms of border, we kind of look for, is it a clear-cut border? Do I know exactly where that border starts and stops? Or is it perfectly round? Does it have a little bit more of a scalloped appearance compared to being, more even, smooth border? In terms of the letter C, C stands for color. So we generally try to look for one or two pretty uniform colors. But melanoma will oftentimes have, 3, sometimes even to 4 or 5. So a lot of times we think of normal moles as being, kind of a lightish skin color, slightly off skin color tan or brown. But in the case of melanoma, you can have dark browns, you can have light browns, you can have reds, blues, whites. So really it holds no boundaries in terms of what color it decides to go to. D stands for diameter, so anything larger than 6 millimeters, which equates to about the size of a pencil eraser, tends to make us look a little bit more closely at that spot. And I think probably the criteria I usually hang on to the most is evolution. So E stands for evolution in the ABCDE. So in terms of evolution, especially if they're over 40 and a person comes in talking about a mole that's changing, it definitely gets us a little bit more concerned in terms of worrying about whether something has a potential to be malignant or not.
Okay, and I want to stress to our viewers, those dots around the moles, those are for the doctor or for
correct. Those are
treatment?
Yes, those are dots that are identifying the location that we would subsequently go on to examine.
Okay, very good. All right, and those moles are certainly nothing that you want to take your fingernail and try to scrape off or anything. You want to leave those alone.
Correct.
Okay, all right. Well, just want to make sure we
Yep.
mention that.
Yeah.
Okay, we have a text coming in, and it is a very interesting one, and don't know where this is coming from, but we thank you for your text anyway. Do redheads get melanoma more often? What sunscreen would you also recommend?
Yeah, so redheads do get melanoma more often compared to darker skin phenotypes. So a lot of times we kind of group redheads with kind of fair and freckled skin versus somebody that might have darker eyes or a darker complexion. The main reason for that is that there's different types of melanin. So there's something called eumelanin. Again, this kind of goes back to the basic science of melanocytes and how they make that melanin. Again, we kind of talked about how even somebody with fair skin and red hair has the same number of melanocytes, but they don't necessarily make the same number of the melanin, and they don't make the same protective type of melanin as somebody of darker skin. So there's two types of melanin called pheomelanin and eumelanin. So eumelanin is a lot more protective compared to something called pheomelanin. In people that have red hair, fair skin, they are having a higher proportion of that less protective pheomelanin, which subsequently is not as protective and leads to a greater amount of potential damage from UV radiation.
So they are at higher risk.
So they are at higher risk, correct.
So we're talking about redheads here. What
Yep.
about people with blonde hair?
Same thing. The blonde hair and red hair kind of go hand in hand in terms of being more of a former of that, probably less protective pheomelanin, not as much melanin.
Okay, very good. And I have a call coming in, and Jack prefers to be offline. He has a good question, I believe. He's asking, is fish oil good for the skin?
Yeah. So I think in terms of, so there's a lot of, research, some validated, some not validated in terms of what is a good supplement for skin health, so to speak. In terms of melanoma, I don't think that there's any research that shows that fish oil is going to decrease the risk. I think the idea behind fish oil is that it helps increase the amount of lipid available to kind of form the protective moisture barrier, but not necessarily in terms of forming the protective melanin barrier that might prevent, melanoma.
Okay. If you're just joining us, we're talking about melanoma tonight on HealthLine, and Dr. Robert Bednarek is with us today. He's a microscopic surgeon, I should say, and dermatologic oncologist. So please call or text your questions in. We'd appreciate that, and we're here to educate you on something very, very important, especially this time of the year. So with everything that you've said so far, Doctor, and I think that I might have melanoma. This looks strange on I'm not saying myself, but if I did, what do I need to do?
Yeah. So the first thing is letting your provider know that you have a spot that you're worried about. Okay. So usually the protocol that goes into place is a person will contact their provider, either their primary care provider, or if they have an established dermatology provider that they're able to get in with to have that area evaluated. Usually when they are evaluated, again, the provider is probably going through the ABCDE criteria that we talked about earlier to get a good idea of whether they think this is something worrisome or not. If it is something that is worrisome, the mainstay to diagnose melanoma is by doing a biopsy. So what the provider will likely do is advise having a biopsy, and generally that's done in the office-based setting under local anesthesia. I think the key thing with any provider that is doing a biopsy is to make sure that they're removing the whole thing. So occasionally you will have people that will do partial samples, or especially of a larger lesion, and that can lead to false negatives. So the most important thing is that you are getting biopsied by somebody that is, mindful that they're taking the whole melanocytic or mole that is of concern, so to speak, because ultimately that goes to the dermatopathologist, and they need all those clues to best diagnose the melanoma underneath the microscope.
And just like any other type of cancer, you have various stages, is that correct?
Correct.
Can you
Absolutely.
explain those?
Yes, so, and that's a lot of what we kind of dictate our management decisions is based off of the staging of these things. So based off of at least the most recent guidelines, the dermatopathologist or the pathologist and that's why it's so important to get that full melanoma specimen if it is indeed a melanoma, is because they are able to get all the clues to accurately diagnose the melanoma, but they're also able to stage it appropriately. So the prognosis of melanoma and the subsequent stage is generally highest or has the most correlation with the thickness. So the thinner the melanoma, the better the prognosis. It's when these things start to get deeper and thicker, that is when we worry about having, spread beyond the skin or even into distant organs.
Well, okay, I was going to ask you, when we say spread beyond the skin,
Yep.
So it can actually spread like any other cancer, getting into various organs and body parts.
Absolutely can. So the way we usually stage these, the current criteria, and again, the derm or the pathologist that's looking at it will give kind of the staging. They usually stage these things after they've looked underneath the microscope. So the things they'll look at is the Breslow thickness is what it's called. So that's what we talked about, has the highest correlation with how patients are going to do in terms of prognosis. They will also look to see if it's ulcerated or not. So funny enough, when you were talking about picking at a spot, we actually don't want them to pick, because having an ulcer underneath the microscope also is a poor prognostic factor versus something that's mechanically manipulated versus the melanoma doing it intrinsically. If it's doing it intrinsically, it's more of a poor prognostic factor than somebody that's picking at it. And then what is called lymph node or spread to the lymph nodes. So regional, metastasis is really the other big one. So depending on the depth of the melanoma and the stage, occasionally what will be recommended is called a lymph node biopsy, a sentinel lymph node biopsy. And that's generally represents the first lymph node that a melanoma would spread had it spread beyond the skin.
I see. So you just go to the nearest territory and then go from there.
Absolutely.
Okay, very good. We have another text from Wesley, it looks like. And Wesley is from Fort Wayne. Thank you for texting us today. He says, I have dry skin and it keeps returning back and healing and returning again. Any ideas what I should do?
Yeah, so this is like dry skin in terms of this. This is more of like a skin health type question, but I think it's very important nonetheless. So really it's moisturize in terms of what you're going to do to kind of maintain your skin health and prevent the dryness, sometimes even 3 to 4 times a day. Minimizing hot showers afterwards will kind of help with the dryness as well. So.
Okay.
Yeah, very important.
And should you douse yourself with some body lotion of some sort?
Absolutely. I call it the soak and seal method. So right after you get out of the shower is the best time to put on your lotion or your moisturizer. Okay. So it kind of soaks and seals in the moisture that you got from the shower, so to speak.
Well, and I don't want to mention any brand names because we're public television, but and I will mention aloe.
Yep.
Is that a good product for the skin?
Yeah, I mean, there is a small proportion of people that do have a contact allergen to aloe. I usually recommend bland old petroleum jelly. I know it's greasy, but the greasier things are, the more occlusive and better for the skin they are. Yeah. So things that you can scoop rather than squirt are generally better for maintaining that moisture barrier.
Okay, that's good stuff. Thank you for that information. So let's talk about treatment options.
Yep.
And I'm sure that the treatment is much simpler the earlier the stage.
Absolutely.
So Go ahead.
And looking at the staging, if you look at what we have, I think it's just so important is early detection. It really is key. So if you look at, again, we talked about that Breslow thickness and how it correlates with how well patients do. The staging is generally based off of how thick it is. So very thin melanomas, the prognosis gets close to 99 to 100% in terms of 5-year survival rates. It's when it starts to spread beyond the skin that we start to worry about, and subsequent treatment becomes a little bit more aggressive too. Mm-hmm. So a lot of times based off of what we call stage 0 and stage 1 melanoma, so the really thin ones, can be treated by an office-based surgery. And surgery really is the mainstay of melanoma when that is an option to treat it. So we like to, surgery, try and treat, has the highest cure rate for melanoma. So if we're able to utilize it, that's what we try to do, even when it is spread beyond the skin. But again, based off of that thickness, surgery is usually recommended first line. If it spreads occasionally, what will be recommended is to sample a lymph node if it goes a little bit deeper to accurately stage, but then also potentially treat as well. So there's been new advances really within the last 10 years that's really kind of changed the landscape of melanoma. So it's always in the past been surgery, and that if it spread beyond the skin, it was a lot difficult, really difficult to treat.
Are we talking about radiation and chemotherapy?
Yeah, so with traditional radiation chemotherapy, probably about 10 or 11 years ago, something called immunotherapy came around.
Right.
And we use it for a lot of, not just melanoma, but it's also used for lung cancer, GU cancers and whatnot. But what it does is it stimulates the body's immune system to fight off the cancer. So effectively, it's using your own cells. What it does is it stops the brake to turn on your body cells to recognize, in this case, melanoma. Really, that's pretty much the mainstay of treatment for melanoma when it's gone beyond the skin, if it's not a surgical candidate to get rid of it. But it really has changed the game in terms of melanoma that's spread beyond the skin, where a lot of times it was, almost a death sentence, I hate to say, probably like 20 or 25 years ago, whereas now we have real, decent evidence that, increased survival and durable responses to where a lot of times these patients respond and they never see it again.
Mm-hmm. That's great news.
Yeah.
News. Another text coming in, and we talked about this a little bit earlier,
Yep.
Doctor, but the text is, boy, I've got to get new glasses. My brother died from melanoma that spread throughout his body. I also had melanoma, but ended up fine. Both of us are the only redheads in the family of 6 kids. How susceptible are my adult children to melanoma in general? None of them have red hair, but have somewhat fair complexion and light eyes. Great question. Thank you for that.
That is a great question. So your adult children more than likely are going to have an increased susceptibility to melanoma. So again, with the fairer skin that we hit on earlier, but family history is something we didn't talk about earlier that is important in assessing risk factors. So having 2 or more first-degree relatives that have had a personal history of melanoma increases, in this case would be the adult children's risk of having melanoma. And in fact, sometimes when you have 3 or more, we will oftentimes send those patients or people to genetics just to make sure that there is no underlying genetic mutation that may be causing that they're melanoma. They're rare, but they do happen.
All right. We only have a couple more minutes in the program. We do have another question coming in. That is a text. If you can go ahead and bring that text up right now, please, I'd appreciate it. Thank you. Is there much of a difference between sunscreen with SPF 30 and higher, such as 50 or 100, as long as they are waterproof?
I think this is a great question.
Yeah.
So, and that kind of goes into the preventative aspects of melanoma. So when we're, in terms of surveillance for melanoma, and this will kind of segue into answering this question, the most important thing is making sure that you're getting a full body skin screening after you've been diagnosed, but then also doing preventative measures at home. So in this case, I'm an ardent supporter of sun protection, but feeds into this. In terms of SPF, what the American Academy of Dermatology recommends is that you are using a sunscreen SPF 30 or higher. It needs to be water resistant, and it needs to be broadband, which means it covers both UVA, ultraviolet A, and ultraviolet B.
Okay.
So in terms of this question, there is really not a huge difference in how much ultraviolet light is being blocked, believe it or not, between a 30 and a 100. It's actually only a couple percentage points.
Wow.
So the biggest thing I will tell you that where people tend to slack is the reapplication. So you're supposed to put it on every 2 hours, or after you've gotten out of the pool or sweat, you should reapply as soon as possible afterwards. So if you gave me the option of saying put an SPF 30 on every 2 hours or putting an SPF 100 every 4, you'll burn with an SPF 100 at 4 hours. But if you do it every 2 hours with the 30, you're going to be golden.
That's good. We only have about 20 seconds left. How can I decrease my risk of getting melanoma?
Absolutely. So again, sun protection, and sun protection. Absolutely. So sunscreen we kind of hit on. You can also, if you're not a big sunscreen wearer, doing sun protective clothing, and just make sure you're examining your skin that you don't see any new moles or anything like that, so that if you do, you catch them early.
I'm so glad you were here tonight and talking about this very important subject.
Great. Thank you so much, Mark.
Yeah, absolutely. We've got to have you back again. Dr. Robert Bednarek, an MD of micrographic surgery and dermatologic oncology. And remember, if you want to see this episode again or any other HealthLine episode, go to YouTube. They're there for you. And we'll be here for you next Tuesday night. Until then, thanks for watching. Good night and good health.
The preceding program on PBS Fort Wayne is made possible in part by...
You gotta find your people.
Good morning.
The ones that make you feel whole.
Good. How you feeling?
You look so pretty today.
Bring it together, you got nothing to lose.
Good job.
In a world full of strangers, you don't know who to trust. You can't go it alone. Everybody needs help.
Go.
You gotta find your people, then you'll find yourself.